All right, so we'll go ahead and get started. Hello and welcome on this beautiful Friday. Thank you so much, everyone, for attending. If you received our reminder email, you know that today we have Christy Granger here from CEI to talk about all the work that she's been doing for AOT in her county and her multiple counties, Clinton-Ingham, Clinton-Eaton, and Ingham. Please make note of questions that you may have. You can raise your hand during the presentation or you can wait because we always have that time at the end to do questions. So as always, before we dive into the presentation, I always want to plug those Q&A sessions. Twice a month, we have those with our AOT expert, Dr. Scott Smith. He's available for a drop-in session on the second Monday at 11 and the third Wednesday at 2. And you can come in at any time within that hour span to bring him any AOT questions that you might have. Nothing is too, trivial. He loves it, honestly. So feel free to come in anytime within that drop in and bring him questions. And that's also a good thing to plug uh, maybe family members or advocates or individuals who may have questions as well. So don't shy away from communicating that opportunity to others as well. So I'll go ahead and drop the September dates for that in the chat. But yeah, so if you have any questions that do not get addressed today, as well, that would be a good opportunity to get those questions addressed. So yeah, without further ado, we'll go ahead and jump into our main presentation, and I'm going to go ahead and kick it over to Christy.
All right, here we go. As Olivia said at the end, we're going to have some time for questions. But if you absolutely have an immediate question, just like let someone know in the chat or what have you, and then I will try to answer that. But today, what we're going to do is spend some time talking about how our team at CEI CMH developed. We've had an AOT team for over 2 years. I know that there is now a new push out there, and we have several grants out there for folks to develop. But this is something that we did on our own, and I'm going to go ahead and talk about it. So we'll start with how it began. Next slide. So back in September of 2020, our CEI administration received a memo from our local probate court asking for a meeting because they had a lot of concerns about individuals who were on assisted outpatient orders or combined orders, and they were not connected to CMH. And they had private insurance, and they were like, what are you doing? Why aren't these people being monitored? Next slide. So with that being said, our administration, they want to know if we get yeah, I'm happy to share the slides. If you guys are good with that. So back in September of 2020, our administration was called to the probate court and we all sat down and had a meeting to discuss this issue. Moving forward, you can move to the next slide. So what they identified is the local courts had identified an increase in individuals coming before the judge asking for evaluations for hospitalization. And it seemed to be the same folks over and over, including those that were on existing orders. So what we were finding is that folks that were already on existing orders, that a lot of lack of discharge planning was happening. There was not any connection to providers. That there was even if they could provide a provider, there was a lengthy wait list. No providers wanting or willing to work with court individuals. There's kind of like this taboo. Oh, you're on a court order. I'm not working with you. There was little education for consumers or providers on assisted outpatient orders. And on top of that, there was a little understanding of how these orders honestly could benefit people. Next slide. So what we ended up doing is the court was like, what are you going to do basically to address this? And this actually had been something that I had been thinking about for a long time and had been talking to the judges about because in our county, we have between 400 and 500 folks on AOT orders. And I knew that a great percentage of those folks were privately insured. And I kept thinking like, what are we going to do? Like, how are we going to reach these folks? So we came up with a proposal. Next slide. So basically, what our proposal was, we wanted to address the following gaps. So we reviewed what are the AOT requirements, what are the actual benefits of the AOT. We also discussed the expectations of the court and the mental health code. And then we had to identify what are needed resources going to be in order to get something up and going. So of course, we're going to need more space. We're going to need the basic office supplies. How are we going to enhance our tracking system? What is our computer system going to look like? And how are we going to reach out to collaborate with private providers? Next slide. So of course, it was additional staffing, additional office supplies, community providers, and funding resources. Next slide. So this is what we proposed to the court for what we would have to start out with staffing. So we proposed that we would need a coordinator. We would absolutely need a secretary. We'd love to have a peer support. We would love to have a mental health worker, and then we would need some client service specialists, which at CEI, CMH are our bachelor level clinicians, and there are monitors. The two hospital liaisons are part of our team, but they weren't part of this funding. It's just someone that they're under my team and they work collaboratively because obviously folks that are on AOTs, most of them are coming through the hospitals. But then we also our agency was able to give us two psychiatrists, and I'll explain that later. Each of them provide us 10 hours a month. Next slide. So the biggest question I get from folks, well, how are you funding this? What are you doing? Because we are not part of the grant, so we do not have that grant funding. So some of it did come from CCBHC, and then our general fund. And the big one is because our courts were seeing that there was such a need in the community for folks to be serviced that are on mental health orders in the private sector. Our court actually got funding for us for one position. So one of our bachelor level positions is funded through Ingham County court system. Next slide. So with that being said, once we kind of put that out there, it was like, what are we going to do? What is this team going to look like? So the purpose of the team was we were going to develop a team that would monitor all individuals on AOT, including those individuals not connected to CMH. We needed to determine the number of staff, which we did, develop the guidelines and the role and expectation of the team, reach out to community providers, discuss the willingness to monitor orders. We'd have to provide education and support to our behavioral health community. We'd need to work with Ingham County on funding, which we did. We would need to provide collaborative training with our probate court to community partners, such as our emergency rooms, primary cares, attorneys, law enforcement. Next slide. The court, their role was going to be that they were going to assist us with one position. They were going to work with us on education for the community, and they would schedule regular meetings with us to review the effectiveness, and then they would review the stats. Next slide. So the process is what happens if an individual is on an AOT and they are connected to CMH or will be connected maybe post discharge from the hospital, or they have maybe transitioned from another county and they're going to be connected to CMH. What we do is after their assessment for services, we assign them to a treatment provider. The treatment provider is the one that is providing the service for the folks under the AOT. However, the court team is the one that's completing all of the documents related to that. So we're doing all the 6-month reviews. We're assisting with any ONCs or notifications of noncompliance, any demands. We're attending all of the deferral conferences. So we're doing all the behind the scenes, and then we're constantly monitoring and getting with treatment providers to make sure. So we're monitoring through our system. Our smart care system is what we use for EMDR and not EMDR, medical records, EMR. And what happens is if folks aren't being followed, we're reaching out to those treatment providers saying, what's happening? Well, you really need to be monitoring these folks. And if they're like attached to a case management team that doesn't have the ability to maybe leave the office and go out and check on them, my court team is doing that. So we're working really closely with the treatment team, just not providing the one-on-one service, treatment service. Also, what we do, I had spoke about, we have psychiatrists. So what my team has is we have two psychiatrists in Ingham, Clinton-Eaton-Ingham, and Eaton counties. We have court every Monday at 1. So what happens is every Monday I have a psychiatrist that is testifying on continuing orders. And then I have another psychiatrist seeing folks for those continuing orders. And then they rotate through the month. So those are folks that, have been placed on the AOT, and the treatment team feels as if they need to continue on the order. And so they are assisting with that. So the treatment team itself will complete like the petition for continuing treatment. And then the court team, psychiatrist will see them and then provide the testimony, so that we're not taking time away from other psychiatrists within the agency, to take out of their schedule, because we know they're booked out 6-7 months, right? And so then you throw a court date in and that messes things up. So that's how we're utilizing our psychiatrists. For the folks that aren't connected to CMH, people are like, well, how do you know who they're working with? Like, where do you even begin? First of all, in the Clinton, Eaton, and Ingham County area, every person who is hospitalized on a petition insert, we get a packet from our probate court. So it starts right there. As soon as we get that packet, we're looking to see if they have a history with CMH. If they don't, okay, do we have any inquiries on them? Have the police ever reached out? Do we have any information on these folks? If not, we go ahead and enter them in our system with what demographics we have. And then we're attending the deferral conferences for our 5 local hospitals. And I'll speak about that in a bit. But during those deferral conferences, that's where we're gathering our information. We're asking the clients, when you leave the hospital, who are you going to follow up with? What is your plan? And so we're getting that information. So if they defer, we're getting that noted on the deferral. If it goes to court, we're putting that on the ATR. And then and for those that don't know, the ATR is something that goes to court with an individual. It's an alternative treatment report, and it's filled out by the CMH, and it indicates what services are going to be available to this individual. So then what we're doing is, as soon as we get that information, we're connecting with their provider. So we're reaching out by letter. We're saying, it's our understanding that so-and-so is working with you, and they are on a court order. Court order information is public. I always get that question. That's a violation of HIPAA. No, it is a connection to services. It is public information. And so we'll connect with that provider, and we will provide a name of a team member here. We will ask them to confirm that they're willing to work with the individual, and that they provide us with regular updates and call us with any concerns. So once again, they're the ones providing the treatment. We're in the backside doing all the little legwork and providing the education and helping them. Then for those individuals, say we're not so successful, they just came in when they had their deferral conference, they didn't know who they're going to work with, and then maybe they're homeless, right? We have a great relationship with our homeless community. So we're out there with our shelters like, hey, if you see so-and-so, let them know. I mean, we need to see them. We're also doing home visits, my team. So the rule of thumb is we do not consider our court order and our team satisfied until we know that the person has had their assessment with their treatment provider and they have made one appointment. If they have not made those 2 appointments, they remain on our team, our responsibility, no matter what their status is. So say they're supposedly working with a community provider, but that provider didn't see them. They didn't show up for their first one. We're out in the community looking for them to try to connect with them. We're using our law enforcement. We are fortunate, being larger community. We have social workers on our police department. on many of them. So we're able to reach out because often they've seen the folks. So that's how we're locating individuals and trying to connect them to services. Next slide. So I want to talk about kind of our success rate with this. Right now, just to give you an idea, we have 253 folks that are Medicaid individuals or indigent, which is 75% of our folks on court orders. And we have 84 individuals on deferrals, so 25% of those individuals. Next slide. Right now, our connection rate for individuals that are Medicaid or indigent, 90% of those individuals have connected to services, and means they've gone through both the assessment and the first appointment, so they're considered connected. We have 10% waiting, and many of those actually we're finding are either currently, like maybe have been returned to the hospital, maybe in substance abuse treatment, or maybe in jail, incarcerated, but we do keep track of those folks. Next slide. So of our Medicaid individuals that are on deferrals, we have 83 of those folks are connected and 17% of those individuals are waiting to connect. Next slide. So our privately insured clients, we have 70% of individuals, so 92 individuals are currently on AOTs, and then we have 40 individuals that are currently on deferrals. Next slide. Of the connection, you can see it's pretty close with our privately insured folks. 89% of these folks are connected, 11% are waiting to connect. Next slide. 93 of these individuals on deferrals are connected and 7% are waiting to connect. Next slide. So just to give you an idea of, our stats, that does fluctuate a little bit, depending. We have some months where we've got so many folks that may be still in the hospital. We're not able to connect with people in and out of the jail system. For our county, though, considering we have so many community partners that are really invested in this, we have lots of ways to track down individuals on orders. We spend a lot of time, on a regular basis, we have monthly meetings with our local ER, our local law enforcement, and we talk about how can we improve on our connection with folks. How can we get it across to like the ERs? This person is on an order, please contact us. We have several things in the works. We have a special envelope we use, so if an individual is being returned to the hospital, say on non-compliance demands, we have a special envelope we use with a sticker so the ER knows that they're to contact the court team. Like I said, we're working with our law enforcement. We do every year we do regular law enforcement training. It's not the CIT training, it's regular court order training, and it's with the police social workers and myself. We usually do a yearly training with our probate court for all community providers, including sheriff's department, prosecutors, whomever. So we do that regularly. We are really super fortunate at CEI because our community really has come together and bought into this. And so, to be honest, we are expanding to a point that I'm not really sure what we're going to do because they're looking to us for so much. Yes, I can send you. I have a whole PowerPoint. Someone's asking if there's a way to show the training. I have a an entire PowerPoint that I can send Sophie and Olivia if they want to share. It's the PowerPoint and the training that we used last July with the probate court. With us, we provide services to Clinton-Eaton-Ingham. The relationship with all the counties are the same. All of the judges are very responsive and support all of these trainings. We are fortunate enough that when we're doing these trainings, they're also speaking. I'm able to call our probate courts on a daily basis. We talk so many times a day we are able to like problem solve cases, and it's the same with all of the counties and the judges. We also are attending all of the court hearings in our county on Mondays for 5 hospitals. Our judge asked for input, so he knows what the treatment, him or her knows what the treatment plan is going to look like. If we have concerns about this client, like it's a lot of open dialogue. In addition, we have an attorney who, for the client, who actually is really amazing. I have no other word. And he works so collaboratively with us and the patient. He absolutely advocates for the patient, but he hears us. He provides a lot of support to us as well. And so that's super nice. So on those deferrals, we've got him. We've got our staff, we've got hospital staff, and we've got the consumer, and we're all in that meeting together each week and talking about, we provide a lot of education because most individuals, this is new to them, right? They have no idea what a deferral is. They have no idea what a court order is. You say the word court order and they think they're going to be arrested, and and so we really spend a great deal of time educating them on that. Um, and and we're seeing, I would say, like I said, a much greater connection to services because folks are seeing that we don't need to use this court order as it's not punishment, right? Um, and then Haley says Mike truly is the best attorney, and she's right. So Haley is our court liaison from Stonecrest, and we're very fortunate in our counties. We have one attorney primarily, Mike. We have a secondary attorney, Brian. We don't get to use Brian very often. Mike has actually asked to do these. He's amazing. Loves to work with clients that are struggling with mental health issues. So yes, we're very fortunate. We didn't have to do a lot of education with him or bring him along because he's passionate about it. And so we're fortunate with that. So moving ahead, I put our pamphlet out there. I know people, have asked, how do you get the information out? We have a pamphlet. We give them to family members. We give them to the consumers. What we often do is if we're doing a home visit, we're providing them with a packet. We also have a little, I want to say goodie snack or goodie bag that we provide to folks when we're doing a home visit, because how uncomfortable, right? You're at home sitting and all of a sudden these strange people knock on your door and say, where you been? You're on a court order. Like you're going to get resistance, right? Our goal is to make it so that folks see treatment as beneficial, that they buying in and they get onto the road to recovery. So what we do is we take out our little goodie bag. It has like a bottle of water. It has pamphlets about mental health. It has a pad of paper and a pencil because a lot of folks, right? They don't have anything to even write their appointments on. They don't know. We have business cards for them. We throw in like some cheese and crackers or something. And then we offer when we go out, if we connect with them, hey, we really need you to come on in, or you need to connect with your private provider. We'll take you to that first appointment. So that's how we are bridging the gaps. Like I said, this wasn't easy. I think I've told this story a couple of times. I've worked in our court department. There really wasn't an official court department, but it was my passion for years to do this. And so I was kind of the court liaison for community mental health while I was a case manager. So I would attend our court hearings, and it never failed that every week I got called to the table by the judge because CMH wasn't doing enough. And what do you people do all day? And there are many days my face was turning red and I had to choke and like go, oh, you know what, Your Honor, we're doing the best we can and blah, blah, blah. And then I'd go in the car and I'm just like, oh, why am I doing this? This is miserable. So one day he was just yelling at me and I'm like, Your Honor, and I told the story Monday. I'm like, I had to kind of like be strong. And I said, Your Honor, just for a second, let's talk about this. You're complaining about these folks not being connected to services that you have court ordered, and you've said, CMH, you've got to do this. They said, but if you or your loved one was placed in a psychiatric facility, and were placed on a court order, but say they had a private provider they'd been seeing for years, or they have like Blue Cross insurance, or they have like a, an HMO, and they have to see certain providers in their network, but you, the judge, said, nope, you got to go to CMH. First of all, you're going to put up a barrier right there. Second of all, they've already built relationships with individuals. And we want treatment. I said, you wouldn't want to go to, like, say, a diabetic specialist if you've already been seeing one and had a relationship. I'm like, mental health is no different. And finally, he says, this gruff voice, Miss Granger, okay, what are we going to do? And it was kind of from there, and that's where the memo came from. And that's how we have moved forward. And I'm really proud to say that it's not perfect. We are absolutely learning every day, but the partnerships we've built for the benefit of the clients are amazing. Our assessment rates, I swear, have tripled at CMH. Um, our notification and demand for hearings right now with the close to 450, 500 people. This all includes, keep in mind, that's everything that's demand or deferrals and initial orders, second orders, continuing orders. We also monitor the NGRI folks. There's, between 450 and 500. With all of them currently, we have 7 outstanding ONCs and demands, which means we are only looking for 7 people at this point that have not connected with some type of service. So now I'm just going to that was like my brief presentation because I wanted to have time for folks to answer or ask questions. So I'll do my best to answer those, and people want to just start, I don't know, put it in the chat or how we want to do that, but I'd love to answer some questions.
Thank you so much, Christy.
Yeah.
This was an amazing presentation. I have questions. I have questions for myself, but I want to hold off just for a second to give other folks an opportunity if they'd like. So yeah, as to echo what Christy said, if you have any questions, feel free to come off mute or you can drop them in the chat and we'll go ahead and address them.
So Haley just asked, only 7. This is Haley from Stonecrest. That's 7 that are at the police department that we can't locate, just to be clear. We've had more hospitalized this week on ONCs. Haley is someone when we work with at Stonecrest. She's the hospital liaison on a daily basis. And so she sees many of our clients. So she's probably like, I probably got that many this week. No, Haley, it's just 7 that we can't locate in the community right now. And then I see Jenny had a question, but let me see what it was. Can you guys see what her question was?
Yeah, Jenny asked, what does your system look like for tracking that many people?
Oh, yeah. So our system, we have Smart Care, which is our EMR system. And so we were able to have our IS department develop a tracking system where what we do is we enter all of the orders in the system, and then there's a system that alerts us to like the 14 days prior. We actually have it set out 30 days prior because you have to, file orders and continuing orders at least 14 days prior. So we have it set out a little bit like a trigger that says, hey, this is going to be due in like 30 days so that we can get them scheduled with a psychiatrist. So we have a system set up for that. NGRI, we also have entered into that system, and we have a trigger for like those that are going straight to the community for the 30, 60, and 90-day reports. And then we also have our 6-month reports in there. Our system is a little challenging because we started it before like the grant funding. And so we had to get with our IS unlimited funds. And so my goal is that we can hopefully update that system a bit. We have a lot of, we also keep hard copies of things for that purpose, just so we have a backup. But yeah, we enter everything into our system. It's right in our EMR. It pulls up, it says court orders. And every time you pull up a client's name, it's not a banner, but it immediately shows if they're on a court order. Our system also tracks how many orders they've been on for the history. Hope that helps. Other questions? I think there were some more. I'm having a hard time seeing the chat.
So Jill just chimed in and she said, is there any possibility of courtesy deferment conference attendance? They struggle with getting info when 75% of the people are out of county.
Yeah, and I meant to talk about that. So this is what we do. We talked about this actually on Monday. You're right. I don't know where Jill's from, but for us, we also have like 30 to 40 hospitals that we're contracting with, most of which are like in the Detroit area or Grand Rapids. And so there isn't, I know the code says, CMH is supposed to be involved in that. And no way in the world can we get to all of those. So what we have been doing is when we get our packet, so like I spoke about, we get a packet from the court as soon as like that second cert's filed. They're setting up the court date. What they're doing is sending us the blank deferral. We are completing that deferral, meaning the recommendations um like we would in an ATR. So we would say on the deferral, like currently open with CMH and this level of care would recommend this, this, and this. And then what we do is we're sending that to our court in the hospital where the consumer is. And what we do, because we're not able to sign off on it, right? Because we weren't present. What we do is we write on the bottom of the deferral, reviewed and accepted by CEI, CMH. And then that's how we're involved in those deferral conferences. Because like you said, there's just no other way to do it. And for us, we have 5 hospitals. So we have in our area, plus we're doing our Wayne County folks. So our deferral schedule is pretty intense. It often takes, about 2 days to get them all in every single week. So I hope that helps answer that question, but it's not an easy one. And I'm not sure where the state will go with that. Cause like and a lot of people, I mean, we're fortunate we have Zoom now, right? Because it used to be, I don't know for other folks, but we were having to travel to our local hospitals every week and do these. And now being that Zoom's acceptable, it's helped us a lot, but there'd be no way for us to do it any other way.
Lovely.
Other questions?
Hey, Christy, hi, it's Carol Doherty from North Country.
Hey.
Hi, it's good to see you in person.
Thanks.
CEI would serve 3 probate courts,
Yes, that is correct.
but how do you handle just the Monday? Do you do all the probate courts?
Yeah, great question. Yeah, so we actually they rotate. So we always have court Monday at 1, but the judges and the prosecutors rotate. So we all come together. So like 1 week it's a Clinton County judge hearing all 3 counties, and then vice versa, Eaton. So that's how we do it. So it's set in that way.
How did you get your judges to agree to that?
So this was something that was way before my time. So it used to be what would happen is the Tri-County area, we would have all of our hearings at St. Lawrence Hospital in person, because at that time it was our only local mental health facility. And so St. Lawrence actually built a little courtroom. And so because a majority of the clients were there, they would just walk downstairs to the courtroom. And that's how it worked. And the judges all came together. But that was probably, I'm not going to date myself, but it's been over 20 years that they'd been doing that. And then once COVID hit, they all just agreed to go on Zoom. And that's how we be able to manage it. Those judges work very well together, and they often attend meetings, all of us together. So we're just fortunate, I guess, is the best answer I have.
Thanks.
Yeah.
So, Christy, I wanted to ask, what skills and experience do you look for when hiring a member on your AOT team?
Yeah. So especially with the peer that we hired, I wanted that peer to have some real life experience. So that was really important because we all know that being able to share your story and relate is pretty effective. And so that was really, really important to me. So that was one of them. As far as my bachelor's level, one of the skill sets is I always say you can't be afraid. You got to be able to talk up. You need to be able to advocate. And I don't even hire people that necessarily have to be like completely trained on the court process. This is a process that is really, it's different and it's challenging and it takes a lot of time. And I always say you can train people on the paperwork, and that's easy enough. But the skill set I look for is, just having that confidence, understanding that sometimes you're going to do things that are wrong and the judge isn't going to like that. And you're not going to talk, you're just going to say, thank you, Your Honor. I'll look at this the next or what have you. So that's one of the skill sets. Obviously, organization is key in this job because there's so much tracking. And of course, most important, having experience working with consumers in general because you have to understand what it's like to work with consumers and where they're coming from. So that's why we work with a lot of the bachelor's levels that do have some case management experience because they understand that. And then a secretary, the kind of the same thing, like someone that's all about working in a difficult situation. We have clients that come in and they're not always happy, right? And working through that. And then we have mental health workers. So the mental health workers are individuals that don't have to have any type of degree, but they do a lot of our transports. So for folks we have a rule of thumb that anybody that is not connected to CMH, say they're in the hospital, but they're going to connect to CMH, are on a court order or deferral, our mental health worker will go and pick them up from the hospital. We have two of them right now, so that we're making that early connection. So they also have to have that advocacy, that patience. I would have to say a lot of patience these days because they make multiple trips to Detroit. And I say that because the construction, and then you've got someone in your car who's screaming, right? They just got out. They want to go home. They don't understand the court order. So the patience, the advocacy. That's what we look for. And just someone that can kind of go with the flow and sometimes laugh and shake your head and say, okay, let's move forward. So,
Thank you, Christy.
yeah.
Do you mind reiterating what is in that packet that you get from the court?
Yeah. So the packet that we get from the court on every individual is a copy of the petition, the two certs, the notice of hearing, a request for the alternative treatment report, a blank deferral, and then that's our packet. So once we get that packet and the MC 97, of course, that would have the demographics on that. When we're getting that packet, then that's what we use to look them up in our system. So our EMR system will show anybody in the Tri-County area that's hit CMH in any way. And it could just be like with an inquiry. Maybe they've called crisis services. So we have that. And so we are looking up their demographics that way. And then reading what we can on them to get the information. And then, of course, like I said, for those that are privately insured and we don't know much, that's when we're reaching out to the hospitals to get that information.
Totally. So I liked when you talked more in depth about the community collaboration that you and your team engage in. Would you have any advice or strategies for folks who are having trouble engaging with their hospitals? Like, do you have any suggestions in that arena?
Yeah, so the first thing I say is patience, patience, patience. And especially, I don't know where folks are coming from, but for us, it all really begins with our emergency rooms. Many folks are coming there, right, on the PRT, meaning that, loved ones or someone has filed a petition, the judge has ordered them to be evaluated, so they're going to our ER. CEI is a little different because we have a 24-hour crisis services on site. So we can do a lot of those evaluations. The only difference is we can't restrain or medicate like the ER. So anyone that's kind of struggling with some aggression and what have you would go to the ER. We are really struggling, or we were, with emergency room doctors saying, this isn't my business. I didn't get into this to do mental health. So that's where we have to do a lot of education. So what we've done with our local ERs is we've had sit down meetings with them where we're bringing like the medical director of our local ER together with the judges. My big advice is that when you are doing anything of this nature, getting your judge on board to be a part of those meetings with the higher ups. Physicians, as a therapist, they're not going to want to hear what I have to say. And I understand that. So it's getting the folks like the judge on board and getting them to the meeting. So that's what we did first, is when we started noticing difficulties with our ER. So what we were noticing is the number, right? The volume of folks coming in on petitions and certs and going to the hospital has been astronomical. But then on top of it, you not only have that, but we have lots of folks coming in maybe for SUD or whatever's happening. But our ER was getting so overwhelmed with it that at points, I don't even think they evaluated the person and they were letting them go, or they'd lose our client. It's like, well, where did they go? And so we finally, with all of those concerns, I kind of kept track of all of those, went before our judge, our chief judge, and she called the meeting. And then that's where we kind of got on board. And that's where we started our collaboration meetings with our local ER. So when I say our local ER, for us, it is the director of the behavioral health department in the ER, along with the ER director. So it's not doctors anymore. That was the initial. And now our regular monthly meetings are those individuals, and we're coming up with systems. So like now, our local ERs and their EMR have a banner system so that when the client comes in, it flashes that they're on a court order, and it will tell the expiration date. We also send regular updates. So if we did an ONC on someone and we know they're going to go through the ER, we send a spreadsheet to them with the new ONC. In our one ER, we actually have CMH staff housed there, and that's what they do all day. Our other ER, they have behavioral health staff, and so that's the staff that we're meeting with. But I'm not going to say that there isn't days I didn't pull my hair out. I felt like I just kept repeating myself, and no matter what we did, so that's why I went to the judge and said, I need help. Like something's going to happen. We have a lot of folks on AOT, or we could use AOT in a different manner instead of just sending everyone to the hospital. And so that's how we made it work.
Lovely.
Mm-hmm. Another thing we do, and I don't know if this is, happening in your counties, but what we're getting a lot of requests for now, and we're trying to navigate, and I have a proposal out to our court on this, is that as we know, the number of folks going to the being requested, having a forensics eval requested is doubled, tripled, quadrupled, right, within the state. And so the wait list to the forensic center is astronomical. We have individuals sitting in the jails, and then they're not getting into the forensic center in time. And then often charges are dismissed, or they're being found incompetent on that one charge, and the judge is like, and they're not going to be restorable. So the judge is then ordering a petition to be filed. We are working with our local prosecutor. So here we have a prosecutor that's a liaison to us. So I have one point person. Her and I work through those cases. So all of those cases that may come through that maybe are sitting in jail and haven't made it to the forensic center yet, or have been deemed incompetent, but we're concerned about what they're going to look like in the community. Her and I work together to develop a plan. And a lot of it is, as we all know, the AOT itself, just requesting AOT with no upfront hospitalization can be a bit challenging because it requires the psychiatrist and what have you. And folks don't always have those resources right away. Like we at CMH can't even get our folks in for 6 months. How do we expect maybe someone that's never been connected to CMH to find someone out there that whether is going to evaluate and provide that testimony or what have you to the court? So with that being said, we have opened up a few of our spaces through CCBHC on our psychiatrist. I talked about the 2 psychiatrists. We've opened up a couple of those slots. So then when the prosecutor has a case such as that, she'll reach out. We'll both agree that, yep, this looks like something we need to do, or no, this person's already connected to CMH. I'm not sure what else we can do, what have you. We will then open those slots up and place those individuals on and look at an AOT that way. We've just had to become really creative in our counties. We've been fortunate enough to do that.
Great. So there was a question in the chat. What advice do you have for CMHs and counties working on developing and building their own AOT programs?
A lot of, like I said, the patients part of it, and also community collaboration, just really getting out there if you can, and meeting with the community partners, getting them to buy in. And when I say buy in, I always say, like, to the police and the ERs, listen, you guys, we're all seeing the same folks. We are all seeing them at a different location, right? But we're all trying to do the right thing for these individuals. And so if we can come together, it hopefully will reduce the work that we're all doing, but benefit the consumers. And just really trying to bring that in, saying, we understand, like the ERs, I always say, I can't imagine what it's like for you every day and the amount of behavioral health clients that are coming in the doors. We get that. We're here to help you. This is what we can do. And then just really getting them to buy in. And it might be like a lunch and learn has been helpful for us. Where we say, hey, come on over. And we always do a lunchtime appointment because folks' schedules are so busy, right? So how do you get like a judge and other people at the same time to come together? So we often do a lunchtime, and we'll say, hey, CMH is providing lunch. Let's do a lunch and learn. Or we're going to do a lunch and learn over the noon hour on Zoom. So really buying that in. Food always helps. But anyways, just bringing those folks together, I think is huge, and it takes work, and you're going to have folks that don't buy in. You're going to have judges that don't buy in. It's just a lot of persistence. And I think when people hear that you really want it for the benefit of the community and the people we serve, I think they'll start to hear that. That's my best advice. Education, education.
Great advice. So what does positive reinforcement look like for you and your team with both like community partners and consumers? Like how do you show appreciation and praise?
Oh, for the community partner, for the clients, that's like what we often do. I'll use a case yesterday or a couple days ago. Individual is discharged from the hospital. So we pick him up, and the hospital had told us, like, listen, he's on a court order. He's going to your shelter, but he needs to come in for an assessment. And so he shows up here. It's on a Friday afternoon. He shows up and he's beside himself, right? He's angry. I didn't know about this court order. I don't live here. I've never lived here. I'm not going to a shelter, like all of these things. And so what we do for that positive, I'm like, okay, let's meet him where he's at. So what we did is we sat down with him and we worked through, like, for him, it was his stressor was he had a place to live. His car was impounded, and he had a treatment provider in another county, but because he was hospitalized through us. So the positive reinforcement was what we did with him is we helped him contact that provider. We gave him a ride on Friday. Because in our mind, you just avoided a crisis. The guy needed a ride. That's all he needed. And if we could get him to that place, so our positive reinforcement for him was we gave him some snacks, we gave him a ride, and we got him hooked up. And that was how he's on that order. Now we transfer that venue, that's fine. But our team worked with him because that's what it's about. And if you can engage individuals and you have to listen to what they're saying and what they're asking for. And that's what AOT is supposed to be about. It's not supposed to be punitive. It's supposed to be just the opposite. How do we get folks what they need? And as far as you said, reinforcement for community partners, I think that was okay. For us, it's a lot of when something goes well, we're thanking each other, a lot of back and forth, like when we've had some really like when things were really getting bad in our community with the ER, when the police would like go and pick someone up, say from the ER, and then the police would turn around and they're right behind the clients, right behind them, like there's no value. Our chief of police got involved and our social workers, and we got it handled. And so what that consisted of, positive reinforcement, was a really nice letter to the city saying thanks for your efforts. Your police chief did amazing work, advocated for us. It's just those little tokens. I learned a hard lesson. You cannot take your police chief or your probate court any Christmas cookies to thank them because they can't accept gifts. So just so you know, so when you're working on an AOT team and you want to do something nice for them, you can't. So it's just a lot of verbal and letters and appreciation. And when someone does something really nice and it's so helpful, like if our police social workers have been extremely helpful to us, I'm reaching out to their supervisor. So that's what we do for our positive reinforcement. Or another way for positive reinforcement that we look at too is, asking them their opinion. We've been struggling with this. What do you guys think? Because we're all working on it together. So using a lot of that has been really helpful. Not pretending like we know all because we don't. And we're also not in the field like some of our community partners are every day. So what can they tell us about folks? What can they do to be helped? So that's what we do.
Mhm. I was also curious with the funding that you have received from the court, is
Mhm.
there any requirements of like, is there anything the court requires you to do to maintain that funding for that one position that they pay for?
At this point, no. However, they keep track of what we're doing. And so this is how I see it working. If we continue to do the work and do good work and people aren't complaining about us, we'll continue to get that funding. It wasn't through a grant. It was like through the county commissioners approved all of that. And so there's nothing specific that we have to do except make sure that we're out there doing the job and working and getting things taken care of is basically what the judge said. So fortunate with that. And we don't have to like do any review documents or show like we don't have to do anything like that yearly to request that funding either. We do a lot of, as far as private providers, kind of my next goal is working with MSU and some of their therapists out there. We've had some contact with them because we do get a lot of students and unfortunately we do get some on AOTs. And so working with MSU to provide those services as well and doing education. So that's kind of our next step. And another big step we're taking is we're working with primary care providers because they'll have individuals that will come in and say, I'm on a court order. I don't understand this. Primary care freaks out and says, who's doing the meds? What's happening? They're on a court order. So now that's kind of where we're branching out is working with primary care providers and we'll get them at a table. And when I say a table, some kind of community meeting to talk about that and offer our support. Like I said, I find that if we offer the support and the education, that they'll buy in and they'll be there. They just don't want they don't want to take all that on themselves, right? And that liability, they don't understand. That's not what they'll tell me. That's not what I went into. This isn't my area of expertise. So if we say, well, come alongside you. So every day I get a primary care provider calling and saying, hey, what can you tell me about this court order? What does this mean? What do we have to do? So.
Great.
Anything else I can answer or do? We do have manuals. I know we're going to be talking about that, but I have a manual that I do share with providers if they want. The manual is literally every type of probate court form we use and we provide. So because we have our crisis services department right here on site, and also ER, we have binders that we share with the organizations, or it's on a PowerPoint, however they want to do it, and it has all the forms and how you should correctly fill out all the forms and construction sheets. That's helpful too, because folks get really concerned. Private providers don't understand, so we do a lot of that. So we do have manuals available, so I think that's super important. Having those available as you're starting up is huge.
Okay. Well, thank you so much, Christy, for coming
Mhm.
and curating this extremely robust space for learning and educating one another. So yeah, we will be communicating the resources that were brought up, that people want a copy of. We will be disseminating those out in a follow-up email. If you are not getting those follow-up emails or the email reminders for this event, let me know. I'm dropping my email in the chat right now. Because I want to make sure that everybody's getting those reminders and the follow-up emails, because that's how we communicate the materials that have been gone over in these spaces. So just shoot me an email. And yeah, thank you everybody for coming today and sharing in this space. I hope everybody has a great weekend and take care.